Well, it depends really if they've had gemcitabine in the adjuvant setting previously, or they've had gemcitabine in the metastatic setting, and secondly, what their performance status and goals of treatment are. If these are patients who have failed after prior adjuvant gemcitabine some time back, it's reasonable to consider gemcitabine-based therapy such as gemcitabine plus Abraxane or possibly even FOLFOXIRI in the first line. If they've failed on gemcitabine, Abraxane or gemcitabine-based treatment in the metastatic setting, then one has to contemplate a second-line treatment in patients who may not be particularly fit. The options in this setting are rather limited. Again, it depends. Patients who have previously had adjuvant chemotherapy and have then failed, I think possibly 50 to 60% might be able to be retreated with some kind of regimen in the first-line setting, metastatic. Patients who've failed after treatment with gemcitabine-based treatment in the metastatic setting, I'd say perhaps 20 to 30% might be fit enough for retreatment. Performance status, goals of treatment, goals of care, for example, desire for survival extension versus palliation, and access to treatment. Fortunately, we have drugs such as Abraxane, such as Folfox, such as oxaliplatin, which are associated with survival benefits in patients, but in the second line, the options are more limited. Really, it's the absence of good data, good randomized trials, large randomized trials showing survival benefit with any agent. The importance of this mechanism of action is that it might result in an improved delivery of irinotecan that is not metabolized or not degraded right into the tumor as a result of the leaky vasculature. In other words, the advantage of this particular liposomal encapsulation might be in the delivery of increased amounts of active irinotecan into the tumor rather than into the liver for degradation. The NAPOLI study accrued about 120 patients in each arm, randomizing patients to liposomal irinotecan with infusion of 5-FU-leucovorin versus 5-FU-leucovorin alone. The overall survival of these patients was about 2 months longer, just over 6 months in the combination arm versus just over 4 months in the 5-FU-leucovorin arm. There was modestly increased toxicity on the combination arm, typical of irinotecan, particularly GI side effects. But in the past, we've known how to manage these side effects with standard irinotecan-containing regimens, and they can be managed in these patients appropriately. This drug and this combination, this indication has been approved by the US FDA. I anticipate it will be available in Canada for the same indication. It will be suitable for patients with reasonable performance status who are interested in survival prolongation and possibly symptom control benefit, and it's a welcome addition to a fairly limited armamentarium.